diminish follicular genesis. So in patients with premature ovarian failure, which is called insufficiency, and diminished ovarian reserves, then when they don't ovulate, then you have to stimulate, get ovum, because the natural process will not occur. Then the poor semen quality. Now, when it comes to poor stream quality, now there are medical and surgical. Now, if you take procedures that enhance the outcome even without IVF. So the medical and surgical conditions surgical interventions play a major role in increasing success of such patients without IVF. So poor semen quality alone is the sole cause in 20% of subfertile couples. And in addition, poor semen quality contributes to another 20% extra when it combines with other causes. So if there is resistance to, or there is no improvement from medical or surgical interventions, then IVF can be recommended. Then when it comes to endometriosis, laparoscopic surgery alone by adhesiolysis, drainage of ovarian endometriomas, restoration of anatomy alone, and diatomizing diatomizing endometrial deposits alone helps even without IVF. And laparoscopic surgery further enhances IVF positive outcome. So the controversies there are, before coming to controversy, now indications, there are other indications for where you need ovarian tissue preservation. So if a patient is undergoing oophorectomy, and then you can preserve ovarian tissue, or patient is undergoing gonadotoxic treatment, where it will have a detrimental effect on ovarian tissues. There is a place the ovarian tissue can be preserved and used subsequently. Then when there is obstructive azoospermia or testicular hyperfunction, now this is where urinary surgeon has intervened and he cannot help. Then when there is obstructive azoospermia, testicular hyperfunction, IVF is very helpful. It's a main mode of successful fertilization. Now, but now if in going back to indications, now we have seen some very young girls without no history of any of these has just gone to a obstetrician maybe 2-3 times or 4 times, and then somebody recommends you go to so-and-so, and then that person, so these people, the IVF centers, they have done IVF, so it is wrong. So, and also IVF cannot overcome the impact of age on oocyte function. So older the person is, the quality of oocytes are low, and the fertilizability is low, and the implantation is also low. And also when the fertilizability is low, the embryos are weak, are not healthy, and as a result, the success rates are low, live birth rates are low. So you can use donor oocytes in such cases. So this, I will first talk to you about the process and where do these malpractices occur. Now, first, when a couple comes, that is, there's a consultation. You have to test the couple. because is IVF indicated in every patient? Just because a patient comes, does IVF indicated? Then if once you select the couple, next is ovarian stimulation, that is, I will go into detail. Then there's egg retrieval, then there's fertilization, then the embryo transfer. So, in the team, there is an obstetrician or a subfertility specialist, and there's an embryologist, and the lab team. So now where do these controversies start? Now, first, at the onset, when a couple comes, we need to assess. So the assessment, part of the assessment is day 3 FSH, estradiol, anti-Mullerian hormone, and the antral follicle count. So then imaging. So we have seen, so the imaging of the uterus and adnexia, where they are, even with IVF, there are conditions that does not need IVF, but a plain intervention surgery. Now, for example, best example here is fibroids, and also endometriosis. I have mentioned adhesiolysis and restoration of anatomy. Then adenomyosis, uterine anomalies. Some of these conditions, the IVF will fail, or very highly unlikely to succeed. So the proper assessment is the patient suitable for this procedure. Then the uterine cavity imaging, because even if IVF will fail in polyps, fibroids, adhesions, submucous fibroids, polyps, and fibroid polyps itself in the cavity, and adhesions due to previous ERPCs or uterine septae, they will have a detrimental effect. And purely by correcting or by intervening to sort out these issues, you can have pregnancies without IVF. Then a hormone profile, whether it is done, because we know the thyroids affects most part of the fertility, most aspects of fertility, and also prolactin, androgen, cortisol. All these hormones affect in a detrimental way. So correcting the hormone imbalance itself is important, and you can have spontaneous pregnancies without IVF. And on the other hand, even if you go for IVF, when IVF is really indicated, these conditions, unless you correct, the IVF outcome will be poor. And the infection screening. So now HIV, hepatitis B, syphilis, then swabs. Now, whether this is needed for every IVF cycle and each time is another question. So restoration of anatomy, correction of hormonal imbalance, optimization of BMI alone is enough to increase IVF success. Is alone enough for pregnancies even without IVF. So if the patient is in need of IVF, still correction of anatomy, restoration, hormonal imbalance, optimization of BMI will positively help the outcome. Now we come to the controversies. Now, who should make the decision for IVF? So in Sri Lankan setup, is it a postgraduate Institute of Medicine board certified obstetrician and gynecologist, or a fertility specialist is involved, or if it is a doctor person from the IVF center or the IVF practitioners? So unfortunately, the people who have gone for IVF, so people whose relations who have gone as doctors, most IVF practitioners are neither obstetricians, neither obstetricians or gynecologists, neither they are fertility specialists, neither they have no form of certification for fertility. Proper, what I mean is proper qualification. So, and most decisions are based on monetary decisions rather than on choice or choice for, rather than the patient doesn't get the best choice. It's based on money. What usually happens is, as I said earlier, when they come to when they undergo treatment and one of their friends will say, go to so and so, and this person will say, okay, the best option is for you for IVF, and then they go for IVF without giving them proper information and counseling. So what are the proper, what falls under the proper patient education, then who and who gives the accurate information? So the process. So most patients really don't know the process. They are not been explained, and they are not aware of success rate. They are not aware of the costs, and they don't know complications and side effects. I repeat, complications and side effects. And unfortunately, we have no statutory law to govern this, and we don't have proper guidelines or protocols. So majority of IVF centers are run by people without proper qualification. So these people have some qualifications, but whether that person has had a proper postgraduate training, even the qualification, though the qualification is mentioned, none of them are registered or registerable in the with the Sri Lanka Medical Council, because some of these qualifications are entry criteria. You have entered a program, but not completed. So the consultants registered with the PGM, registered at the Sri Lanka Medical Council, and degrees and training done by Postgraduate Institute for Medicine, they have completed. Whereas some of these people have entered training programs abroad, but not completed. So they are neither IVF specialists or obstetricians or gynecologists in those countries. And but unfortunately, since the specialist registry is not completed, they still continue to mislead people, and actually they impersonate gynecologists or subfertility specialists. So, and also this, most of these IVS, I repeat, it's most, not all, or they don't have no proper statistics. So they have no data for review for any professional colleges, or even for that matter, for somebody to go and get an idea how successful they are. Now, now what is the role of the embryologist? Now, this IVF, there is the clinician, the gynecologist or the subfertility patient who does the clinical part of it. Then we have the embryologist who does the embryology part of the process. Now, so that is the lab part of the embryo, the fertilization, and once the oocytes are retrieved, it is handed over to the embryologist, and thereafter the clinician comes again into the picture when it comes to embryo transfer. So now we know in some of these interventions are not done by clinicians. Some of these interventions are done by the IVF practitioners who are not properly qualified or trained. And now, when it comes to embryologists, what is the internationally accepted IVF? What is the global norm? Now, are we having internationally accepted uh, uh, IVF practitioners? Are they having the proper qualification? Have they worked in these international laboratories? Have they at least not worked? Have they at least seen? Have they visited? Uh, so what is the standard? So most of the labs here, the IVF centers, the people who are there, I'm not referring to proper qualified embryologists who has the proper academic qualification, proper professional and properly registered and properly trained. I'm referring to people who are impersonating and lowering standards. As a result, the IVF successes will be very poor. So they call them, some of them call them clinical embryologists. And they see patients and this is what I repeatedly said, they impersonate as an obstetrician, a gynecologist or a subfertility specialist, but they consult. So with their MBBS license, they see patients, but they are not consultants, but they, the controversy there is they pretend or impersonate as a consultant. And innocent patients, they come there, they are not given. I have given you earlier their proper indications. So people who have had not even had a laparoscopy or not even had a HSG, hysterosalpingogram, or a laparoscopy, where tubes are not checked, where they have been subjected to IVF. And then with regard to, I would like to move to ovarian stimulation. So the idea is superovulation. You give drugs for to have multiple ovaries so that you can retrieve them to be handed over to the embryologist for to be fertilized in a petri dish. So the stimulation protocols have drugs containing GnRH agonist, antagonist, and gonadotrophy (FSH) is used. So now one controversy there here is, now when there is this part of the cycle, I am referring to genuinely, if a IVF is genuinely needed, yes, this stimulation protocol is costly because the drugs are costly and you need the best drugs. And this takes time. So the best would be a patient, for example, coming from Trincomalee or Anuradhapura, the early part of stimulation can be done in wherever she stays, so that the patients, if the patient wants, the patient can maybe negotiate with the pharmacy or a pharmaceutical company, get a discount for the drugs. The patient can get the drugs locally, so that traveling and then the loss of work, all that, the cost, the indirect cost of this, the traveling cost, all can be reduced. But unfortunately, we know, and some of our patients have shown us photographs of some of the vials or the drugs they have used, and you can't read the name. The name is not there in English. And we got some of them translated to see these drugs are not registered in Sri Lanka. Of course, they are the drug, but it's brought in probably bags. So we don't know about how safe, I mean, whether some of this, if they need the cold chain, whether they are maintained, and they have been charged exorbitant amounts. So this, the start itself, there is really patient is being like robbed from the start. So giving a drug, an inferior quality drug, which is not registered, and which the drug is not being brought in the proper way, and you're charging more than the original drug. So original branded drug. I think it's a really shame on the medical profession when such things happen, and it's very unfair by patient. Then Then what protocol you use? Long protocol or shorter? So minimal stimulation protocol is better because the cost is low, less chance of ovarian hyperstimulation, less chance of multiple pregnancy rates. But there is a problem that the live birth rate is slightly lower than long protocol. So still, considering these three, it can be the cost and less ovarian hyperstimulation and low multiple pregnancy rates, it can be justified. Then this ovarian hyperstimulation syndrome with ascites, pleural effusion, increased liver enzymes, electrolyte imbalance, hypovolemia with and renal involvement. Now, when we work in the periphery, these patients, we see these patients coming in quite, and mainly they go to medical wards. Now, because the patient is not aware that ovarian stimulation can cause this condition. So they're never been told if these symptoms develop to seek advice from a gynecologist. So we see casualty admissions going into medical wards, even they are unaware, and patients will come to us quite late. So this really endangers the patient's life. This is something seriously that the IVF practitioners should consider. And sometimes there are no records. The records are with the IVF center. We don't know what drug, what dose, what is the due, when the patient has got this drug. So the mortality and morbidity can be high, and end of the day, it is we who get the blame for not diagnosing, because the patient is unaware, and until such time we find it, the IVF practitioner doesn't face this any of these problems. It is we who face this problem. Then when it comes to oocyte retrieval and fertilization, patient is unaware. Patient is more unaware of the actual number of oocytes retrieved. And patient is unaware again the number of embryos fertilized. This is not a mistake. This is done deliberately. For example, if somebody has 15 oocytes or 10 oocytes retrieved, and they at least say 8 embryos made, so you transfer about 2 embryos. There is like a net profit, or there are about 6 embryos remaining, which some they call a profit. Human embryos, and then they can sell them to others. So, and also if they have problematic patients where patients demand success, so without consent they transfer donor embryos. So the patient is happy, but sometimes blood groups are matched, so that even at birth it's missed. It can be missed, and unless you do genetic studies, no one will go to do genetic studies to see whether after spending so much and so much hope and what is in your baby in your womb, you're not going to do a genetic study and find out whether it is yours or husband. So so this and also these oocytes are sold, because now there are people who come with poor ovarian reserves. So this is another unethical source of oocytes for ethical source without consent from the donor, nor the donor. The oocytes are used. So they're basically sold. Then similarly with embryos. So if you declare lesser number of embryos, so if you have 8 embryos fertilized and you say you have only 3 or 4, and if those 4 fails, of that's a couple, although they have had 8, they will have to go for a new IVF cycle. because those 4 embryos will be transferred or sold to others. So when it comes to embryo transfer, blastocyst stage offers more live birth rates. So the more mature the embryo, the success is high, but at the same time, the constraint there is most embryos may not come to that stage. So then which stage to transfer and the number of embryos to be transferred differs according to age. So it depends on each center's success rates and the research available. So I have just given some number of embryos, because the lower the number of embryo, lower the multiple pregnancies, lower the so then when you have lower the multiple pregnancy, higher the success rate for live births. And unconsented transfers are done. So sometimes the patient is told there are 2 embryos are being transferred, but actually 3 are transferred, because then the success is high. And even when it comes to multiple pregnancies, they can always say, it's a division, because the patient is not aware of the real outcome after transfer. So when in vitro fertilization with intracytoplasmic sperm injection, which is called ICSI, where you insert the sperm material into the ovum. Now, if the male partner has, if the nature has decided the form of barrier to propagate these genes, so if when ICSI is done, you forcibly send the genetic material. So the risks of IVF by ICSI compared to conventional method is higher. So in a conventional method, you have the ovum and the sperms in a petri dish, and the sperms will go and fertilize the ovum. So they are the best sperm. Like it's a form of a natural selection. Whereas ICSI, you force the genetic material, and this is worse if even you are using donor sperms and using ICSI, and in case if the donor sperm has some genetic defects, ICSI will produce a set of offsprings with genetic defects. And we have seen, it's very sad to say, and it's a shame that patients have been charged for IVF, and only IUIs are being done. This is not what I have experienced. Our colleagues who practice have experienced this set of unethical practices. So when it comes to donor sperm, use of donor ovum and sperms, now we have 2 types of gamete donors. So now say the sister is, one sister is subfertile and she has endometriosis. The other sister gives donor. So it's a family member, one of her best friend gives. So it's not a commercial one. So that donation will be maximum, will be limited to 1, or maybe that sister might give it to another sister or another, maybe twice. But we have the commercial donors. That is, they are paid, they come, they give donors. Now mind you, now what happens is this woman, maybe once in 2 months, 3 months, continuously gives ovum, and sometimes maybe 10 of them, because they call the people whom they give the best yield. That is like you are getting the best salesman who makes the best sale. Similarly, they get the people who gives the center the best yield. So as a result, so Now though the different person is carrying the baby, the biological, the ovum are from a single person. So basically one mother is giving rise to so many offsprings a month or maybe annually. So if you take now, what is the danger there is what happens if these children marry each other. So one mother, so maybe the sperms are from the husband. So the one egg donor having maybe many sperms fertilized with many sperms. However, the maternal genotype is the same. So one day, if they marry, so it's like marrying one mother's children from different fathers. Similarly, now we have the sperm donors. Again, they call people who is like the best, like who gets whose sperms give the best success rates. So again, now we have a set of a single father giving rise to so many children. So as a result, as I said earlier, the genetic, same father's children with different mothers marrying each other. And it's worse when they use commercial mothers and commercial fathers, where the ovum also commercially given and the donor sperms both, and maybe so very similar genotype children might marry each other. So these are the controversies there. And when it comes to sperm, then when it comes to ovum sharing, now there are two kinds. One is what is practice is, if one woman has ovum and no money, and the other woman has money and no ovum, so the person who has money and has no ovum will pay. They share the ovum. So that is ovum sharing. That is so. But what really happens is they hire these ovum donors, and many people pay the same amount. So it's actually not the cost. It's a cost split among four, five people. Each person pays the full cost of ovarian stimulation. So as a result, there's a huge profit gain from this process. So and also they discourage. So these IVF centers discourage friends or family members being as ovum donors. The main reason being they cannot unethically there, because then you can't charge, like then only that person gets a drug and that whoever recipient is entitled to all the ovums. Here is everybody pays the same cost for few number of ovums, sometimes maybe as little as 2 or 3 or 1. So now there are IVF done where the patient has no ovum, the man has no sperms. So why go for donor ovum, donor sperm? Because end of the day, you are creating a completely different embryo. It's neither a couple's mother or father. So it is better, cost effective, and also you far less side effects when you go for donor embryo transfers, because then the ovarian hyperstimulation, oocyte retrieval, all that part of the complications and the cost is avoided. It's just the cost of or whatever you pay for the frozen embryo. But this is but what is recommended is not this. It's again a controversy. Then when it comes to surrogation, now surrogacy. Now actually this is a very difficult area where, say for example, if a sister is not able to has gametes, or has ovum, and there's an issue with the uterus, uterine aging, some form of uterine abnormality, whatever reason. So then we need to get a uterus. So for surrogacy to, for implanted, for the baby to develop. Now, the best would be to get a relative or the patient to find. I know it can be difficult, but what happens is now there are women who are ready for surrogacy, and this is again a commercial basis. So the couple pays a large amount for surrogacy, and the patient gets a very small amount. Well, not the patient, the woman who offers surrogacy gets a relatively a small amount. So again, the IVF centers make a huge margin, but that person, with every pregnancy, every year, her risk to her life because of multiple pregnancies increases proportionately, and her life is at risk. Then inappropriate use of or abuse of drugs. So if you, there are certain estrogens and progesterones are needed for maintenance after fertilization. But if you go through drugs, cheats or regimes of IVF centers, virtually every patient has, in addition, aspirin and low molecular weight heparin. Even for a primate that has had no medical problems, never flat rate, everybody is virtually given low molecular heparin, and we see these patients coming at casualty patient with torrential bleeding, sometimes endangering their life. They don't follow standard protocols, and they don't hand over these patients on time to a obstetrician. They, on their own, they get down the patient wherever they are, or they keep the patient and give these drugs, and virtually every patient gets a cervical cerclage, whether indicated or not. Then unethical or unscientific surgeries are done. Now, I have discussed with my colleagues, there is this tubal clipping or self-injectomies being done. So basically, either you obstruct the tube or you remove the tube. Now, this is done on the context of hydrosalpines, but if you check their records, there is not a HSG, or a laparoscopy where you can see documented by a proper qualified gynecologist stating there is hydrosalpines that being diagnosed. Some people take the consent, counsel the patient by doing 3D scans and showing the patient. The poor patient doesn't know, has seen the 3D scan for the first time, and they say, why you need laparoscopies? Why you need this? I am sure of my findings, but is it possible, or is it somebody who has never had surgeries, who have never had PIDs, never had endometriosis? And the worst thing is the person who has scanned and who comes to the conclusion is not a board certified gynecologist, not a subfertility patient, not a radiologist. It's just an IVF person. And they consent the patient, and the patient, poor patient, doesn't realize the consequences, and they are forced to consent, and the patient with good faith consents, and they have these surgeries. And another thing with where patients who have diagnosis cards or already diagnosed with grade 4 endometriosis, no ovarian tissue, frozen pelvis, and documented no ovarian tissue left. They are having oocyte retrievals. We have managed severe sepsis in patients where oocytes have been retrieved with severe endometriosis, with infection, life-threatening. Some of them had massive ovarian abscesses. Some of them had near deaths. And how ethical and is questionable. And also, when you really know this kind of a patient, you are unable to retrieve ovaries or follicles, why not go for donor oocytes rather than trying a procedure that will not benefit the patient? Then issues associated with multiple pregnancies. So the present recommendation is to avoid, international recommendation, multiple pregnancies as much as possible. Lowest, least number of embryos should be transferred. Because the procedure associated the multiple pregnancies will cause miscarriages, preterm deliveries, then you get gestational hypertensive disorders and gestational diabetes. Now, this is on top of aggravating the existing medical conditions. Some of these when it comes to this BMI, I would like to now talk about BMI modulation. Now, extremes of BMI has very bad outcome on or adverse outcome on fertility because of the differences in the ratios of estradiol and estrogen they make, the total amount of estrogen they make, then the inhibin activin ratios, their progesterone production. So virtually that is ovulation. And then the multiple effects of insulin-like growth factors and their binding proteins. And with obesity, leptin levels are very high. So all this together, and the insulin resistance in polycystic ovary syndrome or the lean polycystic with the androgenics. So extremes of BMI has very detrimental effect on normal pregnancies, on spontaneous normal pregnancy. So control of BMI alone is adequate by diet, not diet, it's a medical nutrition therapy and exercise will increase fertility rates. So if a person has a real indication for IVF, as I have mentioned earlier, like tuberperitoneal disease, poor sperm quality, then they have, such patients will also benefit by changing or coming to a better, the ideal to get into a better BMI, to get a BMI of ideal range. So the hormone profile, the adverse correction of the adverse hormone profile itself will greatly help. And so in summary, what I have to say is in Sri Lanka, IVF is grossly abused in most centers. This is similar to our neighboring countries. I'm not saying in neighboring countries it doesn't happen, but I'm referring to countries with like Singapore, UK, Japan, or USA, where there are standards. So our main issue is starting from the process. We have no law to control it. So when you don't have a law of standards, everybody can do IVF, and that damages or tarnishes the reputation of people who do it the proper way. And and the unethical way of forcing patients into IVF when it is not indicated. And when the patient selection and decision, the making is done by IVF practitioners who are neither gynecologists or neither subfertility subfertility consultants, specialists in subfertility. And also, unfortunately, some of our own colleagues send subfertility patients to them. The reason being subfertility consume times. So if you have a busy practice, it is better to send them to somebody who has time to do that. In return, you get the patient, you get the pregnant patients. But I really wonder how ethical this practice. I think this needs to be regularized. Anybody having IVF, the initial part of stimulation, it is safer to be done by done under the supervision of the gynecologist of that area, because in the event of a problem with the treatment schedule and ovarian hyperstimulation, there is somebody responsible who knows about the patient. And also at the same time, local administration of drugs, the cost and the patient inconvenience, time wasting, the other cost can be reduced. And IVF should be something very valuable, should be practiced the proper way by the proper people in proper centers. There should be regulation. I think the medical council can play a major role with the relevant, our College of Obstetricians and Gynecologists, with the input of our College of Sri Lanka College of Obstetricians and Gynecologists. We can also get help from international bodies to do this. Thank you very much.
Thank you very much, sir, for that very informative presentation. It's time to lighten few queries. Please write your questions clearly in the chat box using standard abbreviations. So we have few queries. The first question is, what is the role of IVF in a patient with karyotyping problem, male and female separately? What would be the chance of success?
Karyotype problems now, if it is translocation, if the karyotype problem is due to a translocation, it will recur. If it is if the patient has got it, if it is non-disjunction, then the chances are low. So these are question I think should be better answered by a clinical genetist. As I'm a generalist in obs and gynae, it's a more of a technical question, because it's a general answer is very difficult. It's difficult.
Thank you, sir. A few more queries. Is there any way that inadequately qualified medical professionals being ligated with regard to this issue?
Litigation.
Yes, litigation.
Yes, it's actually for what has happened. We are aware, the police, the relevant authorities, the medical council, they have adequate information. Unfortunately, some of these procedures have been done by the consenting, the explanation. The consenting has been done by the IVF center. So the procedure has been done by a qualified person. So then the Attorney General Department or whoever, the police department will have the question who is responsible? Is it the person who consented and who explained and consented, or who should be litigated? Whoever did the procedure. So when you are asked to do a procedure, whether you should, whoever did the procedure should take a separate history, see the patient and decide whether the procedure is needed or not, is the question there. So if that is not done, then then it's an issue. Basically what I'm saying is, if the decision has been made to do whatever the surgical procedure and the patient consented, somebody or obstetrician is asked to do it, he comes and gynecologist will do the procedure. That is one way. Second thing is, correctly speaking, that gynecologist before doing the procedure should check whether he should do the procedure or not. So if that has not been done, then it's another issue. So this is the reason why they are protected in a way, because they themselves have not done the procedure wherever these issues have come up. I hope I'm clear.
Yes, sir. Thank you so much. One more question. What is the cost roughly for IVF procedure in Sri Lanka?
So it's a very interesting question. When you go there and sit in front of, this is what has been told to me by my patients. Because I'm board certified from 2006 and I'm practicing up to date. When you go there, it's 280,000 to 300,000. When you talk, and when you start paying, it's about 600 to 700,000. After the first procedure, it's about $1 million. Then once it fails, it's about another 1.5 million. And then sometimes there are instances where they have paid 2 million, 2.5 million, no success. So the cost depends on, I think, the mood of the IVF practitioner that sees you. And some of these people have CCTV cameras and they know which vehicle you're coming and from where you are. So their CCTV will determine your cost. So I think if anybody is going for IVF, better to go in a push cycle or a motorcycle, your cost will be low. Please don't go in very hi-fi vehicle, they can see you. And please talk in Sinhala so that your cost will be less. That's all I can say from the experience what I have had.
Thank you so much, sir. The last question from the participant is surrogation is legal in Sri Lanka?
It is not legal to my knowledge, best of my knowledge. It's not legal.
Thank you, sir. If there are no more queries, I would like to thank Dr. Maitri Chandaratna for his excellent and informative presentation on behalf of the GMOA and Society for Health Research and Innovation. Also, we would like to present a token of appreciation for him on behalf of GMOA and Society for Health Research and Innovation. Thank you very much, sir. And thank you all for your participations also during this hard time. Have a good day. We are concluding our sessions today. Stay safe and stay healthy.